Hey, everybody. Welcome to Tea Talk. It is Tuesday, June 25th. Glad to have you. Tonight, we are going to talk about social determinants of health. That's the set topic. So, of course, we'll also have some open Tea Talk time. So, if you guys have questions or concerns, please make sure you post in the comments. Also, I know we have a couple people that are already on, so please make sure you say hello in the comments or the chat. I highly recommend joining through YouTube. I know some people still kind of take a look through LinkedIn and Facebook, but in my opinion, YouTube is pretty nice from the viewing side of it. And so tonight, I again, unfortunately, am drinking some coffee. I picked up some Starbucks earlier. I actually have a sinus infection, so I'm a little bit sleepy. So I was like, oh, I could use some coffee before the show. So, but certainly didn't want to miss hanging out with you guys tonight. So make sure that again, if you have questions or concerns about the topic, share. I'll answer them during this live tea talk if I can. Of course, I'm only human, right? So I don't know the answers to everything. If I don't know the answer or don't get a chance to get to your question, I'll make sure that I get it answered on the next tea talk or in a message. You can also feel free to put your questions just as a comment after. I know some people catch these episodes after we've aired, so you can always ask, still comment on the video. Also, don't forget to like this video. Give us a thumbs up on YouTube if you like the content for tonight, because that upvotes the video, lets other people know to take a look at it. If you have a more complicated question and maybe perhaps want to share some detailed information, you can always email us also at ttalk@stalkinghorsellc.com. And then for certain sessions and for tonight's episode, I will actually upload a document on our website, which is stalkinghorsellc.com. I haven't done tonight's yet, but I will get it on there. Sometimes I get a chance to do it before the show, but this one I'll do it after. But so as we talk about social determinants of health, I have a little document that I put together for the talk, and I will post it on our website here. And you would just go to Tea Talk, click on Tea Talk again, and then you'll find actually a bunch of different articles and documents on there from different Tea Talks that we've had. Additionally, if you find this topic extra interesting and want even more detailed information, we do have a webinar available on our website in relation to social determinants of health, and it goes into much like greater detail than what we're going to go into tonight, because obviously this forum is for us to build a community and for me to answer questions. So with the webinar, I wouldn't know what questions you would have, but do give a thorough discussion through social determinants of health from beginning to end, go over some documentation, recommendations, and examples. And also with the webinar purchase, you get, I think it's like 7 documents that are included, which includes also the webinar itself, plus different references and resources that were used to put it together as usual. And it's like super helpful information. And I had a lot of fun putting that one together. That was one of the first ones that we had put together. I think it was just prior to starting Tea Talk. But it is a fun webinar. So if you guys have a chance, check that out also on our website. And don't forget to join the herd. So like and subscribe to our YouTube channel here. And also you can follow us on Facebook, Instagram, and LinkedIn. So I'm going to check to see who is actually in the room tonight. Okay. Hi, Ricky from Las Vegas. And Christy, coffee for you. Yeah, you're going to probably be drinking a lot of coffee this week, Christy, because I saw your post on LinkedIn that you're going to be taking your coding exam. I think is it like next Monday or something? This Monday coming up. So good luck with that. We wish you all the best. And if you have any questions or concerns, feel free to shoot a message over. We have a whole team over here, and we love to help mentor others, and we love to see our community advance and grow. And okay, test is Monday. I thought so. I because I was looking at it. I was actually waiting for my prescriptions to come in for my sinus infection. I think I was checking the um, social media. I don't often get a chance in the middle of the day to check social media for like personal reasons, but I did that and I saw your post. So yeah, that's good. Oh, Ricky's got some Chianti going on. Man, well, I guess I could, one of these evenings, I could do wine because I don't drive home from the office. I don't drive myself home. So maybe, just maybe, I'll try that, but we'll see. And hi, Aline from Florida. Thank you again for joining. And oh, Christy, what else do you have going on? Oh, so you're also in the process of applying for billing positions as you study. Are you looking for like you want to stay in billing, or you're just looking for a billing position now until you're coding certified? Just curious, Christy, if you wouldn't mind. And yeah, so it Ricky is fancy. Fancy with his Chianti. And Aline, Coca-Cola. You know, there's something that can be said, like if you're craving like the carbonation, sometimes it's like an ice cold Coca-Cola is really, really good. I know some people that swear by, for some reason, the Coke that comes from McDonald's. I don't know. Something about the level of syrup, the carbonation or something they get right. And a lot of people will like drive out of their way just to get a Coke from McDonald's. I don't know. I don't know if you guys have heard of that, but I've heard like several people say that. And so, Christy, okay, so you're planning on billing as a focus. Oh, you love revenue cycle. That's pretty cool. It's like its own world. Because billing and coding really are two separate things, but two separate professions, truly, but they do really merge together, obviously. And the more you understand about coding, the better you are at billing, and vice versa. So, and I don't think she's on tonight, but we have an excellent biller. Her name's Barbara. She's so fantastic. And when we hear her sometimes talking to some of the carriers about some claims issues, we're like, oh, we're glad she works with us. We're glad she's on our side. And she's done a great job mentoring some people as well. And we have Sonia with us also that Barbara's been mentoring for a bit. And Sonia's really growing and joined us while she was actually working on a coding certification. So she joined us working in billing and still is. And yeah, so it's a super important part. And then the relationship between the coding team and the billing team that we have here is like super important. And it's so fun because neither one likes to disappoint the other. So our team is just awesome. I am very thankful for that. And yeah, it really is cool, Christy, to be a part of both. It is. Oh yeah, connect with her on LinkedIn. Barbara's like super old school. I have to find out. Like, I don't really know for sure. I know she's on some social media platforms. I just don't remember which ones. And then when we were talking about T-Talk internally, she was like, I've got to get set reminders. And so I've got some reminders set and stuff for her. But obviously, not everybody's available at this hour on every Tuesday. So, but yeah, I'll let her know that you'll be looking to connect with her. She's awesome as a mentor. And so, Ricky, yes, fancy. You probably shouldn't drink it from a big gulp cup. Yeah, right. I'm sure you're not drinking from that. sure you have some fancy wine glass because you love your fancy teas. Because I know, because sometimes you've come on here and talked about some teas that I've never heard of, so we won't go there. All right, guys. So it is actually, I've been rambling and yapping. It's probably the coffee, right? So it's 10 after 7. I'm gonna go ahead and jump into talking about social determinants of health. So the acronym is SDOH for social determinants of health. And it has really been a hot topic since last year, but mainly starting in January, it's became more and more important because CMS did write about it in the final rule, but everybody was more focused on the add-on code for visit complexity for evaluation and management services. They talked about that. I mean, at nauseum. They all these platforms talked about it, but I started off talking about social determinants of health because it really, I felt, was undervalued and is a super important concept and topic. Once we dig in, you'll see why I'm saying that. But they really focused on the visit complexity and that being an add-on code for additional revenue. But the social determinants of health, understanding what that involves and that there's risk assessments that can be performed that you can also bill for, that you do get paid for now, starting on July 1st. So that's kind of the reason we plugged it in now on toward the end of June, is because July 1st they start accepting, Medicare starts accepting claims with the risk assessment included for social determinants of health. And so really the story for social determinants of health starts with the World Health Organization, or the WHO. So everybody that's coding certified, probably at least in the back of your mind, you remember hearing WHO or the WHO, not the band, not to be confused with the band, right? But you'd remember the WHO because they also contribute to diagnosis coding, ICD-10. So the World Health Organization essentially is a part of, it's an agency, part of the United Nations that focuses on promoting health for everyone. And it's obviously because the word world, it's across the world. And they have global efforts that they put in place to work on improving health across the world. And with that comes a lot of research and analytics and information. So one of the things that they had focused on for a while was looking into what's called social determinants of health. So social, meaning things that are going on in your life that are of the social nature, but it determining your health, meaning things in your social life that can impact your health, such as financial means. So if you're financially stable versus financially unstable, or if you have financial instability, that could negatively impact your health. You may not have enough money for medication, or if you tend to be somebody that is financially very stable, you probably, especially in the United States, have a better opportunity for better health care. You may be able to afford better coverage. We don't have a one-payer system here. So healthcare here is for profit. So that could really obviously impact your health. Also, if someone has housing insecurity, food insecurity, even as far as their support systems around them. People often talk about like cancer survivors and their outlook on their health and the support that they have from family and friends that has helped them get through an illness. So that's actually kind of generally known, but not really talked about in the US. And interestingly, CMS really started looking into information about social determinants of health because with the information that the World Health Organization came out with, they actually estimated that 30 to 55% of health outcomes are related to social determinants of health. So if you think about that for a minute, that is huge. 30 to 55% of an outcome could be dependent on a social determinant of health. That is insane to think about. So when the Centers for Medicare and Medicaid Services saw this information, they decided, hey, we need to look into this. And so they put out some pilot programs for testing and research that was a part of a financial alignment initiative. And there's reports and such you can find on cms.gov that will go over the finer details of it. It is talked about a little bit more in the webinar that we have available, but point is they go over the initiative and what they put into place, and CMS basically started testing and gathering information in regard to social determinants of health. So they did this research. It was from 2015 to 2018, and they published the information in 2020. So basically, you might say, well, why would CMS be interested in even looking into this? Well, the Centers for Medicare and Medicaid Services, right? They are the government-funded healthcare. That is like the, you get Medicare at 65 and older. Everybody kind of pays into that, right? So it is the government-funded healthcare coverage. So they want to make sure that the costs of healthcare and the outcomes are appropriate. So if people tend to stay healthier, keeps the cost down. And so they're looking at improving the health of the population and saving money for the program. In order to do that, they need to understand, hey, what's impacting health? So social determinants of health impact everyone. It may be a negative or positive impact depending on the person's situation. So with that, the research did conclude that indeed they wanted to continue to gather more information on it. And in order to do that, typically when you ask someone to do more, you have to incentivize them, right? So again, we are capitalistic here. So with them understanding that social determinants of health do play a big role in the outcomes for health, they said, you know what, we want to go ahead and allow and pay for screenings for social determinants of health. So if we set up where we will pick a code, put it out there, tell doctors, hey, you can perform this risk assessment. So it's like a screening. And then you can report that you've performed this. If the patient's at risk for something or if something comes back positive on there, you could then help that patient to get some services or refer them to where they may need to go. And we'll also want that data, that information. So on the provider side, the procedure code, or in this case, it's a HCPCS code. It's G0136. So with that code, there's revenue attached. So if the provider performs the screening and they bill that code, they get the revenue attached to that. They get that paid for. And then the ICD-10 codes would be expected to come in. So the all of the work that they did from 2015 to 2018 was based on data that came in primarily through claims with ICD-10 codes attached related to social determinants of health. So they did add a lot of diagnosis codes for social determinants of health, which Also, interestingly, across the years, through the years, I've had many providers say, well, especially in the ER, oh, well, I have patients that come in. I have some that are like either homeless or about to be homeless, and it is really impacting their care because they can't get to the appointments, they can't get their medications, they don't have a place to live. How can I report that? Isn't there a diagnosis code for that? Wouldn't that make the medical decision making or the visit more complex? I mean, common sense would tell us yes, but in the past, that wasn't really considered. They did even add in there in the E&M leveling chart now that if the patient is significantly limited by social determinants of health, that does raise the risk. So they are now, again, understanding and showing that they are going to account for those social determinants of health in the coding somewhat here. So we've got a couple questions. So would abuse be considered a social determinant? Well, yes. So in some screenings, it would ask about their safety at home and whatnot. And so, yes, forms of abuse would be a social determinant of health. Obviously, if it's physical, that person is at higher risk of injury and needing more care. Even, emotional, psychological, it would definitely be impactful. And yes, that is a part. And Aline, so physicians now ask if you, yes, so they do now ask if you feel safe. A lot of times they'll do that when they're doing their other screenings. The depression screenings really kind of started kicking off some of this as well, which we do have another T-Talk scheduled to go over depression screenings and talk in more detail about the documentation requirements and coding and billing for it. So that'll be interesting. I'm going to share my screen really quick to kind of show you guys the document that I'm going to share. Okay. So this is the document that I put together for today. And I'm actually down at this risk assessment section. So again, that code is the G0136, and that's for administration of a standardized evidence-based social determinants of health risk assessment tool, 5 to 15 minutes. So let's talk about that really quick. So it does need to be a standardized evidence-based tool. There are multiple out there. Even if you just put it in Google or Bing, you will be able to find some. I do have an example that I will share, but you will be able to find some. Also in the webinar that we have, it goes over some additional examples in more detail, and there's some additional links that are in that webinar if you choose to take a look at that. But it can't just be something that is thrown together by the practice. It has to be something that's evidence-based and standardized. So there are risk assessment tools out there already, which again is probably a good thing and a relief to most practices and providers, because you don't want to have to reinvent the wheel or just create something without really knowing like what are we really looking for here, and what has the World Health Organization used, and what's kind of tried and true and shown some kind of result, right? That's going to be meaningful. So let's take a look at what else we have here. So again, those claims start being accepted July 1st. So that's basically right here, right around the corner. Now, an important note is that if it's performed on the same day and billed by the same provider on the same claim as an annual wellness visit, you can append modifier 33 to the G0136 to have the copayment and deductible waived. In addition to that, it's covered once every 6 months when provided with an E&M or behavioral health service on the same claim and data service, but the copayment and deductible will apply. So basically, they recognize also that circumstances and situations can change through a year. So you can do this risk assessment, perform it more than once in a year, and it will be payable by Medicare. Now, keep in mind that not all carriers view this the same. So if you want to check your commercial payers, your commercial carriers, and check your fee schedules with them to see if they've added the G0136 to be sure. I know some have not. So you just need to be sure who covers it, who doesn't. I also know some practices that just choose to do these screenings, as well as depression screenings, every time the patient is seen, even though they know that it's not necessarily covered. They just do it as a service to the patient. So you also want to make sure that you don't consistently inappropriately bill those improperly. So there's certain modifiers that you can attach, especially if it's to Medicare, that will let them know, hey, we know we're not going to be covered for this. It's we like, you would then be saying, hey, we understand that we're going above and beyond our allotted amount. We're not allowed to perform this service more than, once every 6 months. But if they're performing it, if they want to be tracking it, you may still be asked to code it. But that's going to be something that's going to be specific to each organization and how they're going to handle the situation. But I do know that some practices already just do that with depression screenings, regardless of if it's going to be payable, because they want to make sure that they are screening their patients and checking in with them on some of these more sensitive issues every time they're seen. So that's going to be, again, more specific to the practice, the organization, and the providers, and what their decision is as far as when it's medically necessary to perform and all of that good stuff. So next I have an example of a screening tool. So this is the American Academy of Family Physicians, and it is available on their website. I really liked this tool because I just feel that it's straightforward, it's easy to understand, and it's not overly complex or like voluminous with just information. So it's very specific. It has the areas. So like housing, it's questions specific to their housing, food, transportation section, childcare, employment, education, finances, personal safety, as we just were talking about, even utilities. And it goes over scoring instructions. Everything is included in here. So if this screening is performed, we would expect if this document itself is used. So some practices may say, hey, we're going to use this, but we're going to incorporate it into our electronic system, so it's going to show up where the patient can click on like an iPad of some sort or something to fill it out. Others are going to say, hey, they're going to fill it on paper, we're going to scan it in, but the document, the scoring, should be able to be seen. So we would not expect for it to be billed without being able to see that the screening was actually performed, that the scoring was also completed, and then the most important thing too is the provider's interpretation of that. So if there is some kind of positive finding, we would expect to see some elaboration. So suppose that the patient fills out this screening and we see that there is, let's pull this document back up. Let's say that we see that there's an issue with food. So this says within the past 12 months, you worried that your food would run out before you got money to buy more. So let's say that was often true. And then within the past 12 months, the food you bought just didn't last and you didn't have enough money to get more. Let's say that that's often true. So if there's some positive finding there, we would expect that the provider would mention that, the risk assessment was completed. We would be able to see the risk assessment, that there was positive finding for food insecurity, and that the patient was what action was taken, who were they referred to, how was what advice was given, how was the situation handled. And so that also can be a little bit scary at first for a lot of practices because they're, feeling like, okay, well, what do we do? How do we handle that situation? Because it's not historically, it's not really always been something that every practice has assisted with. So the good news is it's very easy to search online for community resources in your area. So I would recommend each practice to do that and then make contacts at different organizations that are local to that area where the practice is, where your patients are. And when you make those contacts, uh, they can also help provide you with more information and even give you cards, pamphlets, or information on how your patients can contact them for assistance. So you can use those community resources, put a document together for the practice, and then hand that information out to the patients um, to be able to cover this situation. There are additional services that can be billed that a practice can set up. That's another Tea Talk topic. That would be like another hour and a half discussion. But if you're just looking again at just talking about the risk assessment for social determinants of health, this is a good place to start. Actually, performing the risk assessment, documenting it properly, billing for it, getting the patient's referrals for the resources that they may need. That's what we're looking for. But the documentation does need to describe what was done. So we need to know that it was performed. We need to be able to see that the screening was performed. We need to know the results of it. And even if it's negative, the provider can just say that the risk assessment for social determinants of health was performed and, it was negative. There are no findings at this time. And if they choose to say when they may want to repeat the screening, they can or not. But um, even if it's negative, we need to know that the providers reviewed it and interpreted the actual screening. So the same as in depression screenings, but again, there's another Tea Talk coming up on that. So that is just one of the documents that's available for the screen for a screening tool. After the provider documents whether there's a finding or not, then the question is, okay, what do you attach to the actual procedure code, right? So I mentioned before that they came up with diagnosis codes, ICD-10 codes for social determinants of health. And I do have on this document something from Medicare. Let me share here. So Medicare has this document out. There's a link down here. Also, I will put this again on our website. But they talk about Z codes, what they are, how do you collect them, and reporting them. And one of the great things about this document is on the last page here. I'm going to make this a little bit bigger. They go over social determinants of health Z codes categories. So, for example, they have a code now for homelessness, and it's been updated to say whether the patient is sheltered and homeless or unsheltered and homeless. And they have, so many Z codes now that may relate to social determinants of health. So if there's a positive finding, the proper Z code would be able to be appended to the G0136. So you would just add these Z codes in and attach to that HCPCS code for the screening, and it would be good to go. Now, if there's no finding, there's a Z code that's available for a screening, and that can be used, but it wouldn't then add some kind of social determinant finding. It's just a basic Z code for reporting for screening, for reporting that you're performing a screening. So I think that, again, they're going to be using these ICD-10 codes, and the fact that they are now going to pay for the social determinants of health screenings, they're going to be getting so much more information through these ICD-10 codes on the impact of social determinants of health, that I wouldn't be surprised if in the future some of these Z codes end up risk adjusting for those that are on risk contracts. So that's also just an interesting concept to think about, because remember that Medicare has actuaries that basically do their own analytics on diagnoses that are reported and the cost of healthcare. So they're going to use these Z codes as both a way to help determine the quality of the healthcare being provided, and then possibly also as far as a payment, possibly within risk adjustment. Okay, we got some questions here. So Aline, how do you determine if there's enough information to state that there are social determinants? Well, you're allowed to take what the patient's reporting. So, I mean, if you do the risk assessment and the patient's being asked those questions, either the form can be provided, handed to them, or someone could be asking them these questions. I do think that's also, though, important to chat about for a moment, because some of these questions are going to be rather sensitive, right? Especially the ones about feeling safe at home, or, because if there's any abuse going on, you never know. I mean, they may have someone with them, right? They could have their abuser with them. You don't know that. So this information is and can be a little bit sensitive. And so thinking about how the practice, or how your practice would actually want to deliver the screening, is super important also, because it shouldn't be treated as just like another document to just like hand out and sign, like, oh, here's your patient forms, just fill them out and sign them. It may be necessary to take the patient aside, or wait until they're placed in a room, or actually, if there's someone with them, maybe you need to remove them and say, we have to take, patient in to this other room for screenings. We'll bring them right back. And then ask them the questions or give them the form. But you do want to make sure that they feel comfortable, that they feel safe with filling the form out, and that they also feel that they can be honest. And I think, again, that goes back to that visit complexity, right? So the whole point of Medicare now also paying for that visit complexity has to do with relationship building between the patient and the provider. The more comfortable you are with your physician, or the more comfortable your patients are with you as the clinician, the more likely they are to be honest. So building that trusting relationship is very, very important. Sometimes, too, patients tend to build a close relationship with certain people who work in the office, may not necessarily be closest to the provider, but maybe closest to the nurse, or closest to the medical assistant, or someone else there. But gaining a level of comfort and trying to help the patient feel comfortable and secure in a way that they will answer questions honestly is important too. So when the screening is provided, so you can give it to a patient just if they're coming in for a regular office visit and they haven't had a screening, you can just provide them, you can just offer that screening, ask them to take the screening. If they're coming in for an annual wellness visit, you can provide the screening at that time. And again, if you provide it at the same time as the annual wellness visit, if you add that modifier 33, they won't have to pay for their deductible or their copay, coinsurance. That will be waived. So you can just give it to them during a regular office visit. And when they fill out the document, let's say that they report that they are homeless and that they are not sheltered. The provider doesn't have to go and confirm that they are homeless. You're allowed to take what they're reporting on the screening as at face value as what it is. I mean, I think it'd be very unusual for someone to fill it out in a way where the dishonesty is, making the situation seem worse. Usually it would be that they wouldn't want to share that sensitive information. Normally wouldn't be the other way around, because the idea of this screening is to get them access to resources that can assist them with those problem areas. And so then you're saying, would it be the physician's opinion? So the document, let me go back to the document really quick. Don't want to make you guys dizzy. Sorry, hang on just a second here. Let me take that off so you don't have to. Sometimes I know like just the scrolling through will be like, ooh, make you dizzy. So, all right, I'm to that page. So once they have filled out the screening, there are scoring instructions here. So it's going to tell the provider and the staff how to come up with the score. And then it states here, greater than 10 equals positive screen for personal safety. So there's instructions and information on how to score it and a little bit on how to interpret it. And again, based on what they state on this document will help the provider to just know if they need to make any referrals to assist the patient in any way with financial needs, food needs, maybe some kind of help with paying a utility bill, or some information to help with their education or employment. So they'll know based on the screening what agencies or what referrals they may give. And you know, a lot of these places that can help would be like just community centers or churches, have a lot of like outreach. I know there's a lot of communities also that have places that are specific for men, places that are specific for women. So there's typically community resources available pretty much everywhere. It's just, again, for wherever your practice is located, doing the background research, getting information available. Typically, if you do it once and you put together some contacts and you make contact with people at these different agencies, and you start sending referrals, that relationship is typically going to build and work out well. I do, though, recommend that once or twice a year you follow up and make sure that those resources that you're referring patients to obviously are still active and working, because it'd be terrible to refer someone somewhere for food assistance just to find out that there's no food pantry available there anymore. So you do want to have somebody available to kind of like check up on that. Again, there's some other health integration services that a practice can provide, but that goes a little bit deeper beyond just the screening that we're talking about here. So we may be able to do a T-Talk on that if you guys request, if people request to kind of hear more about that. I'm just not sure how many practices right now are actually doing that. I felt that it would be good to start off with talking about the screening and risk assessment and get practices used to doing that, rather than jumping into some of these other services that could be provided that are deeper. They're kind of deeper in. But this, again, kind of goes in line with the depression screenings that most have become accustomed to, as well as other services like advanced care planning, and even for patients that have like several chronic illnesses, the chronic care management services. This all kind of like goes together, like in that realm of, you know, we're now going beyond just the, hey, I'm sick, give me, you know, some medicine or tell me what to do, and I'm kind of, that's it for my appointment. You know, we're moving forward with trying to provide more quality care and preventative care services. Honestly, sometimes I feel like some practices go a little bit too far. I know that where I am, it's sometimes extraordinarily difficult to get in to my doctor's office if I'm sick. And I've had issues with that in the past where you call up and you need to schedule a sick visit. They're like, hey, we don't have any openings, because a lot of them, all they're doing now is just preventative wellness visits, filling up their days, and they're not leaving sometimes enough slots for sick visits. Thank goodness my provider, if they don't have any openings, they're offering like telehealth services like after hours for sick visits, which is awesome. But yeah, it has not always been like that. And in the past, I've actually had to leave some practices before, because if the only time you're going to see me is when I'm healthy, I don't like that, because I don't want to go to the emergency room. That's why I have an established relationship with my primary care provider, because I don't want that high cost. I don't want to go to the ER. I don't want to be exposed to, those germs and the high costs. I don't want to have to pay more for, my deductible and whatnot. And even going into the walk-in clinic or urgent care tends to cost me more than it is just going to see my primary. So if I have something simple where I don't need to go to the emergency room, but I still need to be seen, I want to be seen by my primary care. So it's also important to understand that too. So it's like keeping that balance is important between, working on quality care, preventative services, but then also leaving space to treat the patients. We can't just have full practices of just wellness visits and whatnot. Doesn't make any sense. And you're not really helping to care for the patient, the whole patient, right? It's only when they're healthy. No problem, Aline. That makes sense. Okay, good. Perfect. Yep. The scoring is what makes like a big difference there for sure. So, but the ICD-10 codes, if you guys haven't checked them out, I highly recommend you do. I know some of our codes of the day, we have done several using some of these social determinants of health ICD-10 codes, and they're pretty fun sometimes too. To pick something out and be able to use it. I think some of like sibling rivalry stuff or parent-child relationship, sometimes there's some fun videos on that. So that's pretty cool. We just are this next, I don't know, like 10 days or so, we've got some pretty funny ones that I know are in the queue to come out for the code of the day. So I'm pretty excited about that. So Christy, we are taught the Z codes in school. Yes. And Z codes, it's kind of weird, I think, when you're actually first learning about coding. So for providers that may be joining that don't know a lot about Z codes, and then for any new billers and coders, Z codes are a little bit confusing at first, because you start thinking, okay, I've got the procedure code, and then it's got to have a diagnosis. But when is it okay to have a Z code? Because usually we think of Z codes as just history codes, like codes for a condition that no longer exists, but there's a personal history or family history of it. But there are Z codes for, tons of different things. I was just talking yesterday about Z codes for when a patient is coming in to receive chemotherapy or radiation. Like there's Z codes for that are primary codes, primary listed diagnoses. So interesting, Z codes kind of are a lot bigger than what we would think. And they're going to be, I believe, adding more to the social determinants of health Z codes as time goes on. I think they'll get even more specific. And as I said, maybe even impact payment if a practice is part of a risk contract or has any risk contracts. So yeah, the Z codes are interesting and kind of fun to learn. It's just amazing what you'll find in there. I know, like, there's even status codes too that are Z codes. So let me share this document. I think you guys can see it okay. Let me go a little bit bigger. So this document too even talks about like when some of these codes were added. So I mentioned that report came out from CMS in 2020. So you can see in 2021, they added several of these ICD-10 codes in here for more specificity, which makes sense. And then again, they added several in 2023. So every year they're for sure going to be adding more until they feel that they've pretty much captured everything that they can think of. And just as a reminder, new diagnosis codes come out October 1st. Well, they become effective, right? Active October 1st. So it's one of those weird things too that providers and newer coders tend to forget. So when October 1st hits, you'll be looking at the 2025 ICD-10 codes for October 1st dates of service through the end of the year. So you'll be looking in the code book for the next year for those dates of service. Then anything prior to October, you'd look in the 2024. The other codes, then you use those like CPT and HCPCS in January 2025. So that's also one of those weird, quirky things. We have to watch out for our software too, because software is not always updated timely. So you do want to make sure that your practice's software is updated in time to be reporting those active codes come October 1st of the year. So for that year. Anyway, well, I think that, again, is a pretty well rounded overview of social determinants of health. I don't think I've missed any questions. I'll be sure to go back through. If I've missed something, I apologize, and I'll make sure I get an answer to you, but I don't think I've missed any questions. If you guys, again, if you think of anything, just make sure that you either post a comment after we go live, or you can email us at ttalk@stalkinghorseLLC.com. You can visit our website. You can even send us a message through there. Don't forget to thumbs up this video. I appreciate your guys' time tonight. I think next week, I believe we're talking about depression screenings next week, I think. So again, let me know if you guys have any other questions or concerns. Thank you so much for joining tonight. I think it was a nice tea talk and a very important topic. Don't forget, we have that webinar if you want to check it out. So thank you guys. Have a great night, and I will see you next Tuesday.